This video is in support of the Texas Orthopaedic Surgery Collaborative Value-Based Registry. Reviewing the background helps understand why changes are necessary. Why do people go into medicine? Well, it's intellectually challenging. It's a fairly well-respected job. It's usually a secure job. It involves science and art, and we all have a desire to help people by ending suffering and saving lives. And for the students of Buddha, you know the first noble truth is that life is suffering, and it's true that the human condition includes sickness, old age, and death. That's just par for the course. And science agrees. The SF-36 is a global measure of health, and you can see in this British study that for all demographics, richer people are blue and poorer people are green, that physical health decreases as we get older. The good news is that mental health increases. So why did we go into medicine? Well, you get paid to make a difference. When someone has a health issue, you do something, you choose a treatment, or you give advice that has an impact on patients' lives. And it's true, we often can make substantial differences. We can make the blind see, the ENT doctors can get the deaf to hear, the psychiatrists can often calm the demons. Our public health system is called from around the globe to help out in crises, and most physicians have never seen a case of polio, leprosy, or smallpox in their careers. Cardiologists can often raise the dead, and the orthopedic surgeons allow the lame to walk. And it's very clear that we don't all make the same difference. Dartmouth Atlas shows that there's substantial variation between regions in the country. The butterfly graph on the right shows that the number of total knees done per 1,000 Medicare beneficiaries varies from 2 at the bottom to almost 17 at the top. Part of the reason is that we're allowed clinical autonomy. Surgeons choose their own indications, their own techniques, and we all like to try new things. Many criticize doctors in the United States for being cowboys because of the variation in services that we actually provide. Do we always make a difference? There's a huge amount of uncertainty about what really works. Much of the care that we perform lacks strong evidence base, and results often vary depending upon whether you study a research population or the routine care that's provided in the community. The graph on the bottom is from a British Medical Journal article, and it shows that up to 51% of the things that we do in medicine have unknown effectiveness. And despite the freedom for this great variability, we're not paid by the difference we make. We're paid purely by the volume of the services we try to provide. Physicians are paid by how many patients they see in clinic. Surgeons are paid by how many surgeries they do. Hospitals are paid purely for the volume of patients that come through their emergency rooms or get to stay in their hospital beds. The equipment companies are paid by how many braces or total knees or total hips they sell, and drug companies are paid for every pill that they deliver to the community. And if you're paid by volume, you do a lot of it. In fact, in the United States, if there's any hope it can help you, the system profits to provide it, and most patients want it done. After all, happy patients are satisfied customers. The slide on the right is from the MedPAC group in Washington, and it demonstrates the growth in the volume of practitioner services from the year 2000 to 2012, and you can see for almost every item the volume has gone up. More imaging, more tests, more procedures outpatient, more doctor visits, and more major procedures, like what I like to do, total hips and knees. And this is not a new finding to the economists. Kenneth Arrow wrote on this topic in 1963 after Medicare became a law. He noted that physicians are not under any control, and it may be convenient for them or pleasing to their patients to prescribe more expensive medication, private duty nurses, more frequent treatments, and other marginal variations of care. And it's often these marginal variations are the small things that doctors and businesses market heavily to try and generate volume of business to their offices. Unfortunately, these new things often make very small differences, and they're usually quite expensive. If you remember the formula value as outcomes over cost, the tiny differences these marginal variations make and the high cost that they generate to the system provide very low value to the patients, and the society. But patients want it all. They interpret expensive as meaning better as long as they don't have to pay. In this article from Health Affairs, they gathered a focus group to highlight what patients thought about clinicians thinking about the costs of care. They found that patients want the best care regardless of costs, that they have very little experience with trade-offs between health and money, and that they really lack interest in the costs that are borne by insurers and society as a whole. This non-cooperative behavior when it comes to money is known as a commons dilemma. This tragedy of the commons has been noted by just about everyone who studied the healthcare issue in the United States. There is no incentive for individuals to try to hold down costs, and those who do, in effect, are penalized. Garrett Hardin was a biologist who wrote a paper in Science in 1968 that basically said, if you let all the players have access to a common good, then the system is bound to fail. He said that ruin is the destination toward which all men rush, each pursuing his own best interests in a society that believes in freedom of the commons. And healthcare, in effect, is a common good. The threat and ruin is well known. The United States spend more than any other industrialized country. Our costs are certainly the highest. But when ranked against the other industrialized countries, our quality is not. The highest score we rate is on patient-centered care. We give patients what they want. The toll on budgets is the real threat. Businesses feel a lack of global competitiveness when they have to spend so much on medical issues, and the government is finding a dwindling amount of money that can be spent on other federal non-interest spending issues. Things like infrastructure, defense, and things that most orthopedic surgeons value too, like research and education. The rapidly growing costs of Medicare and Medicaid are crowding out the money we have to spend on the other issues that are important to America. Government's response has been to decrease the reimbursements for the things that doctors do. The slide on the left shows that ankle fractures, rotator cuff repairs, spinal fusions, and total knee replacements have all gone down since 1992 in what they get paid. The only line that goes up is the Consumer Price Index, and that controls the overhead to our offices, the people, and the real estate that we need to be able to see patients. The slide on the right we've already seen. The response to these decreasing reimbursements is that the healthcare system does the only thing that it can do. It does more of what it's been doing. With the current payment mechanisms, it's the only way the health system can pay its overhead. After all, no margin, no mission. And you'd think that phrase would have come from a greedy business guy, but in fact, it comes from somebody else. The phrase no margin, no mission was coined by Sister Irene Krauss. She was a school teacher turned nurse, and the founding CEO of the Daughters of Charity National Health System, and the first woman chairman of the AHA. So trying to find a way to maintain health providers' margins while not breaking the national bank is a priority, and both sides of the aisle have signed on that things have got to change. And the thing that's going to change is changing how physicians and hospitals are paid. Both Republicans and Democrats have asked physicians to come up with a way to eliminate the standalone fee-for-service payments and transition to an approach that's based on quality and value. And so things like modified fee-for-service and quality metrics and contracts are something that we're likely to see. The Texas Value Registry is one way to try and address these changes that are being forced upon us. And perhaps even more importantly, can help serve as a mechanism to generate the evidence that will help better manage the patients for whom we care.